Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is October 15, 2025. This video is on a study titled Danger Shock Criteria and Outcomes in Acute Myocardial Infarction Related Cardiogenic Shock Treated with Impella, the J-PVAD registry, published in European Heart Journal recently. The objective of the study was to assess outcomes of danger shock. Study was to assess the outcomes versus eligible versus ineligible acute myocardial infarction cardiogenic shock patients treated with Impella in the Japanese JPVAD registry. This is a nationwide multi-center registry between 2020 to 2023. 3,975 patients with acute myocardial infarction related cardiogenic shock were enrolled. Classification 5 groups: eligible STEMI cardiogenic shock, non-eligible STEMI cardiogenic shock, out of hospital cardiac arrest, mechanical complications, and non-STEMI cardiogenic shock. Eligibility criteria: a lactate above 2.5 millimoles per liter, a blood pressure less than systolic blood pressure less than 100 millimeters of mercury, or catecholamine use, left ventricular ejection fraction less than 45%, and Impella initiated less than 24 hours from the onset of shock. Stats: Kaplan-Meier estimates, Cox regression with hazard ratios, interaction p-values, and subgroup analysis using multi-variable models. What did they find? 30-day mortality, 37.6 in eligible STEMI cardiogenic shock, 27.6% in non-eligible STEMI cardiogenic shock, 51.3% in out-of-hospital cardiac arrest, 39.8% 30-day mortality with those with mechanical complications, and 33.3% in non-STEMI cardiogenic shock. Risk factors: age above 80, VA ECMO use, IHCA, that is in-hospital cardiac arrest, renal dysfunction, and hypoxic encephalopathy increased mortality. Impella-related bleeding: 15.6% in eligible STEMI cardiogenic shock. Key insight: only 35.6% of real-world patients meet danger criteria. Individualized risk assessment is essential. Statistical significance, p-value less than 0.001 across mortality and complication comparisons. Clinical pulse: Impella is widely used outside trial eligibility criteria. Real-world evidence matters. Eligibility matters. Meeting danger criteria was associated with higher bleeding but comparable mortality. Out-of-hospital cardiac arrest without return of spontaneous circulation has the highest mortality. Patient selection is critical. Multimodal risk assessment tools may be needed to tailor Impella use. Time to support less than 24 hours remains a strong prognostic factor. Recently, I had done an earlier video on a New England Journal of Medicine article titled Long-Term Outcomes of Danger Shock Trial. Quick comparisons between the Japanese and the Danish danger shock trial. The danger shock trial was a randomized controlled trial in Denmark and Germany. The Japanese JPVAD registry was a nationwide prospective registry in Japan. In the danger shock trial, 360 STEMI cardiogenic shock patients were enrolled, and in the JPVAD study, 3,975 acute myocardial infarction cardiogenic shock patients. Only 35.6% met the danger criteria. Outcomes and results: in the danger study, 10-year survival improved with Impella, hazard ratio 0.70, that is greater than 600 days of life. With the JPVAD registry, 30-day mortality is 37.6 in eligible STEMI cardiogenic shock, various across subtypes. Clinical insight: danger trial supports Impella use in well-selected STEMI cardiogenic shock, while the JPVAD warns of real-world deviations and need for tailored shock protocols. Killip class classifies MI severity and risk of shock. John T. Kimball, MD, was co-author with Dr. Thomas Killip of the seminal 1967 paper which introduced the Killick-Kimball classification, a bedside tool for stratifying heart failure and severity in patients with acute myocardial infarction to predict in-hospital mortality. John Kimball was a cardiology fellow, and so he hasn't got much press for it. Legacy: the Killick-Kimball classification is still widely used globally in clinical practice and trials. It's a bedside triumph of clinical observation guiding prognosis in the pre-echo, pre-PCI era, epitomizing the art meets science era of cardiology. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.